This is for the syncope. And the next very important topic is infective endocarditis. So infective endocarditis, from the name, it has infection, and endocarditis, the affected layer is the endocardium. Carditis, the inflammation of the endocardium due to an infective cause. So this infection of the endocardial surface of the heart typically involves more or equal one, or maybe one heart valve, maybe more valves are involved. And the causative is mostly bacteria. Fungi may cause infective endocarditis, but more commonly you will find different bacteria that causes that. Here you may find the candida as an example of fungi, and the others are bacteria. They are subdivided into acute and subacute. So you have to know that acute means that it occurs rapidly, and so the causative organism must be highly virulent. And our example here, and the classical example, is Staph aureus, very virulent organism causing acute infective endocarditis with large destructive vegetation. There is a large destructive vegetation, rapid onset for this, for the acute. And for the subacute, the less virulent organism here are examples. The classical example is a virulent streptococci. So you have to memorize well that the Staph aureus causes acute infective endocarditis, virulent streptococci, low virulent organism causing subacute infective endocarditis. And the unlike the larger destructive vegetation for the acute infective endocarditis, you may have a smaller vegetation on as long as this organism is non-virulent, unlike Staph aureus, it has to be on top of congenitally abnormal or diseased valve to take advantage of it. So maybe a sequelae of dental procedures. So very famous for the streptococci to cause infective endocarditis, and you may have to take the prophylaxis. We're going to go through that later. So has a gradual onset. So have to know that the virulent streptococci are the ones that related to dental procedures. So for the symptoms, very high yield to know that you have the vascular phenomena, septic emboli, and the ossular nodes, and so. But you have to know just that a lot of patients may present only with fever. This is the most common symptoms the patient may have. So you have to be very suspicious in the patient have fever, and just auscultate well if there is a new murmur as mitral regurgitation or so. So fever plus new murmur or fever only, are the most common symptoms. You have to be very suspicious, along with the vascular phenomena. This is the vascular phenomena and the immunological phenomena. These are the characteristic phenomena, but not have to be in every patient. So for the vascular phenomena, of course, there is an vegetation with a lot of organisms, so this may form an embolus, very logical. So if this embolism occurs, it is called septic embolism, and it also has petechiae. And for a very characteristic vascular phenomenon here is called the splinter hemorrhage, which splinter hemorrhage means linear hemorrhage. So this is a linear hemorrhage here in the nail bed. This is a splinter hemorrhage, very, very high yield to know that. And another vascular phenomena is something called JNY lesion. So the JNY lesion just means painless. Very you have to know they are painless and they are flat, erythematous lesions on the palms and the soles. So the splinter hemorrhages are on the nail beds. They are like of lines on the nail beds, linear hemorrhagic lines on the nail bed. Unlike the JNY lesions, they are in the palms and the soles and erythematous flat, and they are painless. So this is the vascular phenomena. And for the immunological phenomena, this is kind of due to immune complex deposition or maybe glomerulonephritis. You may have glomerulonephritis associated with endocarditis, and ossular nodule. This is ossular nodule is kind of painful, unlike JNY lesion, painless. So the JNY lesion are painless and flat, but ossular nodules are painful and raised, and there's a violaceous lesion on the finger or two pads. So for another immune phenomena is Ross spot, which means retinal hemorrhagic lesions. So this is a retinal hemorrhagic lesions, and it has pale center. So this is for Ross spot. You have to know that the mitral valve is the most commonly affected by infective endocarditis. This is a mitral valve, and it is more than the aortic valve, but there is a specific kind of population which are IV drug users. When you inject the drugs, you inject it into the veins, so the veins drain into the right side of the heart. So in this specific population, the tricuspid valve involvement is the most common. So the tricuspid valve involvement is associated with injection drug use. So you have to memorize this kind of organism as well. So for each kind of procedures, there may be an infective organism which is specific. So for if you have a prosthetic valve, it is commonly associated with the staph epidermidis, and for the gastrointestinal and the GU procedures, enterococcus is commonly associated, and for colon cancer, staph galolyticus. So prosthetic valve, staph epidermidis, GIGU procedure, enterococcus, colon cancer, staph galolyticus, and they're less high yield called HACEK organism or HACEK organism, and the Haemophilus, Aggregatobacter, and the Cardiobacterium, and the Echinella, and the Kinginella. These are all the organisms are gram-negative organisms, are grouped together: Haemophilus, Aggregatobacter, Cardiobacterium, Echinella, and the Kinginella. And they are, you may find the infective endocarditis and the culture became negative, and when this occurs, you may suspect that the patient has is infected with Coxiella or Bartonella. These both organisms may not be detected on culture, so you may have a culture negative infective endocarditis due to Coxiella and the Bartonella. And in the, remember, in the injection drug use population who has tricuspid valve, most commonly involved with the most common organism is Staph aureus and Pseudomonas and the fungi Candida. So the hallmark about the disease is endothelial injury and the formation of vegetation. These vegetation are infected, so it will not only contain platelets and fibrin, but also includes the microbes on the heart valves, and as acute effect is valve regurgitation, and maybe a septic embolism if the systemic circulation in the left side or if the right side. So for the tricuspid valve involvement, it will drain through the pulmonary artery, and the final destination is the lung. So the lung is the final destination, and unlike the left-sided vegetations that may travel up in the blood till reaching the systemic circulation. So this is for the left-sided versus the right-sided. The diagnosis, of course, multiple blood culture, very high yield to know that you are not gonna withdraw single blood culture. You have to withdraw concurrent central and peripheral blood culture, and you may need multiple blood cultures, and you have to do an echocardiography to show the vegetation. This is vegetation for infective endocarditis, but another kind of disease which is less common, it's called the non-bacterial thrombotic endocarditis. Another name, Rheumatic endocarditis. From its name, it's called the non-bacterial endocarditis. It's inflammation and thrombosis, but does not involve the bacteria. So it's called the Rheumatic endocarditis. So the vegetation on the typically arises on the mitral or the aortic valve and consists of the sterile platelet-rich thrombi, and it does not contain microbes. Unlike endocarditis, can dislodge easily, and as long as they does not contain microbes, so they are usually asymptomatic until embolism occurs. So just kind of associated with hypercoagulable state in advanced malignancy such as pancreatic adenocarcinoma. So the use this have this kind of groups. The pancreatic adenocarcinoma, the cancer is hypercoagulable state. So specifically pancreatic adenocarcinoma, they may have thrombosis and unexplained embolism. This and different kind of groups that they also may have non-bacterial thrombotic endocarditis is a systemic lupus erythematosus, and in this case it's called the Lieberman sac endocarditis in this setting. So either malignancy with hypercoagulable states and having a thrombosis and emboli, or systemic lupus erythematosus. The magnetic endocarditis or non-bacterial endocarditis is called Lieberman Sachs endocarditis in SLE. So next topic is rheumatic fever. So the rheumatic fever is a consequence of pharyngeal infection by group A beta hemolytic streptococci. So group A beta hemolytic streptococci. So this is a consequence of it. You have to know the organism group A beta hemolytic streptococci. So the late sequelae of rheumatic fever is rheumatic heart valves or rheumatic heart disease. You have to know that the mitral valve is more commonly affected than the aortic, and the tricuspid is least common. So the high pressure valves are more affected, and you know that the mitral valve from rheumatic fever is very famous. Mitral regurgitation acutely, and the valvular stenosis at the end. So in the acute phase, you will have early valvular regurgitation, and on the longer term, you will have valvular stenosis. So you encounter many patients in their 40s or 50s who have mitral stenosis from rheumatic heart disease. Very, very common, and you have to suspect that on the longer term. So on histopathological level, ash of bodies, anti-Schau cells is just to know the name, not very high yield. Ash of bodies means granuloma with giant cells. So on the pathological level, granuloma with giant cells, it has a name here, ash of bodies. And anti-Schau cells, just the macrophages is called the anti-Schau cells here, but the macrophages here has ovoid, wavy, rod-like nucleus, and is called anti-Schau cells, and the granuloma is called ash of bodies. It also, of course, it is famously associated with increased anti-streptolysin O, but you don't have to depend on that for the diagnosis. Here's the Jones, famous Jones criteria. So you have to know that affects the joint, but the form is very important. You know, for rheumatoid arthritis, this is very destructive for the joint, unlike systemic lupus or rheumatosis, which may mildly hit the joint. But here, the big characteristic thing is the migratory character of the insult. So rheumatic fever affecting the joint is in the form of migratory polyarthritis, and affecting the heart in the form of carditis, and this is two more common forms. And you also have to know the rest of the three. The nodules on the skin, subcutaneous nodules of the skin is also one of the criteria. So joint affection in the form of migratory arthritis and the carditis, and the subcutaneous nodules also kind of erythema, which is called erythema marginatum, is kind of if nascent trash with kind of ring margin. Just know erythema marginatum and the Sydenham chorea. We will go through that in the neurology chapter, which means just for now involuntary irregular movements of the limbs and the face, Sydenham chorea. So the immunological defect behind that is type 2 hypersensitivity reaction. So you have to know that rheumatic fever is not the direct effect from the bacteria, but there is something called the MO protein. The MO protein antibodies are formed against that MO protein. So the M protein is part of the bacteria, and in the same time there is a myosin. This is a myosin. So you have antibodies to against the M protein, which will cross react with the self antigens, which is the myosin. So the treatment and the prophylaxis very high yield. The penicillin, you will give penicillin for treatment, and the patient may be put on a prophylaxis for many years with penicillin. So the syphilitic heart disease. So the syphilitic heart disease, you have to know very well that occurs in the tertiary syphilis. You have primary, secondary, and tertiary syphilis. So this occurs in the tertiary syphilis, and the syphilis here will disrupt something called the vasa vasorum. So these are the vessels supplying the vessels. So you have the aorta, and it is a vessel, and itself it has a vascular supply. So this vascular supply for the aorta is called the vasa vasorum. So the syphilis will affect the vasa vasorum, and the consequent effect is the atrophy and the dilatation of the aorta and the valve ring, and this will lead to something called the tree bark appearance due to just atrophy and calcification, and the accumulation of that will give you something characteristic called the tree bark appearance. So you just know that the affected part is the vasa vasorum. It will affect the aorta, and may result in aneurysm of the ascending aorta, aortic arch. So it hits this part of the aorta, not the whole aorta, not the abdominal aorta, the ascending aorta, aortic arch. Just know these areas that are affected, and this may consequently lead to aortic insufficiency. So you have acute pericarditis and constrictive pericarditis. Acute pericarditis is acute form, and on the long term, just fibrosis will ensue, and you will have constrictive pericarditis. So for the acute pericarditis, it also means, of course, it means inflammation of the pericardium. So this is inflammation of the pericardium here, and of course, the character of pain of pericarditis is very famously known. The sharp pain, increased with inspiration, relieved by sitting up and leaning forward, very known. It's often just not acute pericarditis, but may have super added effusion as red arrow here. So this is effusion between the heart layer and the pericardium. So pericardial effusion as a part of acute pericarditis, and by auscultation you will have friction rub and ECG changes. So the ECG changes for acute pericarditis, you will have SCT segment elevation, very high yield to know that. MI also STEMI will have SCT elevation, but the SCT elevation for STEMI occurs in a specific region. You may have inferior STEMI, so anterior STEMI, lateral STEMI, but here just widespread or diffuse ST segment elevation on all of the leads, and PR depression. This very characteristic ECG picture for acute pericarditis, and usually the cause is idiopathic, most common cause of pericarditis, but maybe viral infection. Coxsackie B, remember that we talked about trypanosoma cruzi and Chagas disease and malignancy, metastatic pericarditis, and sorry, so yeah, just know that viral infections such as Coxsackie B virus may cause it. Trypanosoma cruzi causes cardiomegaly. So here it's viral infection is a cause for acute pericarditis, malignancy, and metastasis. You may have malignant pericarditis. Cardiac surgery is a patient coming to the CCU after cardiac surgery. They may have acute pericarditis, and radiotherapy. So radiotherapy is subdivided into the early phase and the long term. So the early phase of radiotherapy is acute pericarditis, may cause acute pericarditis, but on the long term, the thoracic radiotherapy may lead to fibrosis, and on the long term, the formation of constrictive pericarditis. MI, so you know, post-cardiac injury syndrome, other name for it, Dressler syndrome. You will have, remember, there are two types of pericarditis, peri-infarction pericarditis, which happens, I remember, just 2 days and onward after MI, and the several weeks after myocardial infarction, you will have something called the Dressler syndrome, which is called the post-cardiac injury syndrome, very high yield. And autoimmune disease, of course, cause pericarditis, such as systemic lupus and rheumatoid arthritis. They are kind of syndromes, and pericarditis is part of this syndrome, systemic lupus and rheumatoid arthritis. And there is uremic pericarditis, of course, and the treatment for uremic pericarditis is dialysis. They are just the patient has renal failure. You don't have to you shouldn't have to give him NSAIDs or colchicine or glucocorticoids. Just give him put the patient on dialysis. So this is one of the indication of dialysis with pulmonary congestion and hyperkalemia, and this kind of different indication of dialysis. The uremic pericarditis, of course, it is an indication for dialysis, very high yield, and the treatment NSAIDs, colchicine and glucocorticoids. Last topic here is constrictive pericarditis, chronic inflammation, unlike acute pericarditis, and this will lead to pericardial fibrosis plus or minus calcification. So this just like strangulates the heart, and this give a limited space for expansion. So consequently, there will be decrease in ventricular filling, and usually it is idiopathic, but maybe due to viral infection, cardiac surgery. You remember the same causes that we talked about in acute pericarditis, but we are talking about the long term, and very high yield to know that if the vignette involves a third world country and a patient coming from a third world country, you have to suspect of the TB, and it is the most common cause in resource limited countries. So this kind of strangulation will decrease the endodiastolic volume, and by starting mechanism will decrease the cardiac output. And when you decrease the cardiac output, the venous return, of course, is gonna decrease. So the patient may have dyspnea, peripheral edema, jugular venous distension, cow's milk sign, pulsus paradoxicus, pericardial knock, all the different kind of right or left heart stuff, heart failure stuff. So This is for constrictive pericarditis. I hope you guys enjoyed that video and learned all of about the pericarditis and different kind of diseases of the heart: infective endocarditis, syncope, cardiac tamponade, shock, and high output heart failure. And see you guys later.